Good morning to everybody. My name is Jorge Gonzalez-Martinez. I'm a neurosurgeon, and I do epilepsy surgery. So I would like to thank the Childhood Epilepsy Surgery Foundation for this nice invitation. It's always very nice to talk with family members and colleagues. You are the reason why I took this career, and I'm very, very honored to be here to talk with you. What we're going to talk today, or in the next 15 minutes, will be about hemispherectomy, which is probably one of the most, I would say, invasive procedures that we do in epilepsy surgery, not only in kids, but also in the whole epilepsy surgery field. And what I just want to first to clarify to you is that we perform hemispherectomies, or the disconnection or removal of the hemisphere, when patients have medically intractable hemispheric epilepsy, of course. And the definition of medically intractable hemispheric epilepsy is a severe life-threatening seizures arising from a significant damage or disease cerebral hemisphere. And as you know, the etiology for this type of pathology can be quite variable, including, for example, vascular or ischemic, like perinatal infarctions. This is one of the reasons why patients, they have hemispheric epilepsy. It can also be caused by what we call malformation of cortical development. During the cortex development intrauterus, you can have a malformation, and then this malformation can cause seizures. The other etiology is infections, encephalitis, and probably the most common, or not the most common, but the most well-known etiology related to encephalitis is what we call Rasmussen encephalitis. And another group of patients is what we call Sturge-Weber, which is a malformation of the PO vessels, the cortical vessels in the brain, and this can cause further inflammation and finally will cause seizures. So those are the etiologies of what we call hemispheric intractable epilepsy. And when we perform this connection, and when we perform this removal of the hemisphere, of course, our surgical goals, as you can possibly imagine, is the completely cessation of seizures. This is the ultimate goal of the operation, is completely stop the seizures. But also, another important goal of our procedure is to minimize the risks of the operation. As you can imagine, there are significant risks in performing hemispherectomy, and is our role, is our mission as a surgeon, as an epileptologist, to make sure that we completely minimize any procedures that we do to our patients. So what are the risks of hemispherectomies? So risks can be included as hydrocephalus, which is the dilation of the ventricles after removal of the hemisphere. You know, the ventricles are those water spaces inside the brain, and those water spaces can be dilated, or it can be obstructed, and this can cause what we call hydrocephalus. And hydrocephalus is eventually a quite serious complication, because it may get worse and may get worse complications or worsening neurological outcomes for our patients. So something in terms of maybe another surgery, a shunt needs to be done if the patient develops hydrocephalus. The other risk of the procedure is blood loss. So again, the more young our kids are, the more sensitive they are to blood loss, and we need to be very, very careful in terms of blood loss for those patients. This is not, as I mentioned to you, necessarily a minimally invasive procedure. This is a procedure that requires a large craniotomy. This is a surgery that maybe takes 5 or 6 hours with many times blood loss. So it's very, very important to have a very good anesthesia team and a very good ICU team to handle those patients. So it's not only the surgeon, the surgical team, not only the epileptologist, but also the anesthesiologist and the ICU that will make sure that those patients will be completely stable, be completely recovered from the surgery. Another possible complication during surgery is hypothermia. The smaller the kids are, the more sensitive they are to low temperature. And again, That's to highlight the value or the importance of the good anesthesiologist for those patients. Coagulopathy also is a serious complication that we see, and this is normally seen when we remove larger portions of the human brain, an anatomical hemispherectomy. They do well after 24 hours, and after that, after 1 or 2 days, they develop what we call post-hemispheric coagulopathy because of the removal of the brain tissue. The brain tissue has anticoagulant agents, and this can cause coagulopathy after surgery, and it's eventually there is a chance there will be an intracranial bleed after the hemispherectomy. So those are the details that we need to really to pay attention. It's why I cannot overemphasize the importance to have a good ICU team to treat our patients. And probably the last complication I would like to mention to you is what we call accepted meningitis. So when we talk about meningitis, we get scary. Meningitis, we always have this imaging of, bacteria or contagious disease, very severe. Accepted meningitis is a disease that is a complication or morbidity related to the procedure, which is related to the inflammation of the tissue, of the remaining human tissue, due to the persistence of blood products in the cavity. So what the patients they have is after 24 hours, they start having high fevers. And those high fevers is due to not to an infections, not to a bacteria, but due to this inflammation. In general, this is a very benign process that requires steroids as a treatment, and after 3, 4, 5 days, those high fevers, they subside, and patient will become back to normal with normal temperature. So those are the main risks or main complications that we should attempt to minimize while we're performing hemispherectomy. So that's the reason why there is a modification of the techniques over time. And again, the more experience we have with those procedures, the more we realize how can we minimize the procedure in order to obtain the same results or better results, and also to minimize the complications. So again, there is a tendency when we see the patterns of evolution of hemispherectomy, there is a tendency to perform less invasive procedures over time, so with less cortical removal. So when we talk here, this is a picture of an anatomical hemispherectomy. As you can see here, a CT scan that shows a complete removal of the hemisphere. And there is a tendency in the new techniques to minimize this resection. So this is because in part to prevent complications that occur with larger resections. Also, this is in part due to the improvement in the understanding of the etiology, and we understand that now we don't need to remove completely the hemisphere, but we can do a partial removal of the hemisphere, or maybe doing just a disconnection of the hemisphere. And also, this evolution also comes due to improvements in surgical technology. Now we have microscopes, now we have image guidance, a special GPS that can guide us to perform very precise procedures. So those are the details that explain to us why there is this translation from maximally invasive procedures to less invasive procedure. Okay? So this is an example how we perform an anatomical hemispherectomy, just a picture of a patient. Normally, the kid would be in what we call a supine position with head rotated, and we do, as you can see here, a large T incision with a large craniotomy because we need to expose the entire hemisphere in order to perform an anatomical hemispherectomy. But as I said, this large procedure translates in many cases to much less invasive procedures, as you can see. This is X-ray, a lot of X-rays, as you can see, with a craniotomy. And you can see here, this is a small craniotomy, what we call a keyhole craniotomy. And we can perform the disconnection of the hemisphere, not anymore by removing completely the hemisphere with larger craniotomies, but through this little tiny craniotomy that we can go there and we can disconnect the hemisphere. So this is just to illustrate to you how this evolution occurs in epilepsy surgery and for hemispherectomies. So a little bit of this historical perspective. The first hemispherectomy was done by Dandy in 1928, so it's been a long time ago, almost 90 years ago. And this was not done for epilepsy, it was done for brain tumor. So, but this was the first time that this procedure was performed. The first hemispherectomy for epilepsy was performed by Mackenzie. And then Krishna in the 50s now performed this procedure systematic in patients with epilepsy. And of course, as I said, our goal is to minimize complications. The historical series start with anatomical hemispherectomies. And finally, in the 60s, there were several reports of complications of worsening in neurological outcome after hemispherectomy. And this was correlated to what we call today superficial hemosiderosis, which is the impregnation of the blood or the remaining bleeding inside the ventricle after anatomical hemispherectomy that will cause this inflammation and will cause dilation of the ventricles. So in order to avoid this complication, another neurosurgeon, Rasmussen, developed what we call a functional hemispherectomy, which is not an anatomical removal of the hemisphere, but a disconnection of the hemisphere. And this is just a classical picture of what we consider to be a functional hemispherectomy. This is a schema showing the hemisphere here. This is the frontal portion, the back frontal. This is the temporal. And this is a temporal lobectomy, explaining what's the functional hemispherectomy. A temporal lobectomy followed by a posterior disconnection, an anterior disconnection, and a full callosotomy. So those are the evolutions, a disconnection instead of removing the entire hemisphere in order to avoid the superficial hemosiderosis. More evolutions we have in 1992. Finally, Delalande described the modified functional hemispherectomy. Villemure described the peri-insular hemispherectomy, which is just the removal or disconnection around the insular cortex, which is a small area in the brain that you can just go around it, and we can do the hemispherectomy or the disconnection. And finally, Strang showing the keyhole approach with a little tiny craniotomy, and you can remove or disconnect the hemisphere. What's important here is, does it make any difference in terms of outcome? For sure, in terms of complications, it does. You know, in general, the smaller resections or the smaller approaches will bring less complications. But the question is, does this bring better outcomes or maybe equal outcomes than in comparison with other techniques? So this, in general, the efficacy of all hemispherectomies, they are similar. So there are no difference in any what we can see in the papers published, that there are differences between anatomical and functional hemispherectomy or all other variations. They all have the same results. So the decision regarding which technique use appears to be a surgeon's preference. What is the surgeon trained with? What is he most comfortable with? And this is probably the most important factor in relation to what technique your surgeon should apply for your child to do this type of procedure. Of course, the decision also is related to the intraoperative concerns, the age of the patient, the necessity to avoid short postoperative courses, and of course the desire to minimize the procedure. But I just want to make sure here to say that there are no prospective studies, no clear study that shows that one technique is better than the other. So again, my take-home message here to you is that whatever is your surgeon preference, whatever is the most experience for him, probably that would be the best approach for the patient. So this is an example. This is a perinatal infarction MRI showing this large cavity patient with hemispheric epilepsy. And here is, as you can see here, there are dilation of the ventricles, a big opening space over here. And in that way, it's very straightforward for a surgeon to do a less invasive approach when you can go through the insula and we can just disconnect the whole hemisphere through a small opening. This is just another example how we perform. This is just a specimen showing this is the hemisphere. So this is the top of the head. This is the dorsolateral. The head, the eyes will be just in front of you. So this is what we call a coronal view. And those are the cuts that normally the surgeon needs to do around the insular cortex in order to disconnect the whole hemisphere. And again, there are other techniques that can be applied. For example, Delalan used a more vertical approach, when instead of doing the approach from the side, as I showed you before. So there is a technique that we can go through here, through the top. And this will eventually avoid blood loss complications because you're going through areas in the brain that has less blood supply. So again, the etiology, when we compare the several series, they are between 70%, 65%, some series report 80%. So overall, the report of the outcomes in all those series, they're quite similar. But the question that I have for you, and this is always what intrigues me, is that if we're going to remove the entire hemisphere disconnected, the outcome should be 100%. So why some patients will not, they recur from seizures, right? So there are several reasons for that. So the first reason that we need to think, it's about bilateral disease. And sometimes this bilateral disease cannot be diagnosed before the procedure, or it can be diagnosed before the procedure, but there is maybe a chance that removing the hemisphere or disconnecting the hemisphere will stop the seizures, despite the fact that there is bilateral disease. So examples of bilateral disease is malformation of cortical development, Rasmussen encephalitis. I'm not telling that all the malformations of cortical development will have bilateral disease, but they can have bilateral disease. And of course, perinatal infarctions, also they can be bilateral. But probably the most common and the most important failure for or hemispherectomy is what we call an incomplete disconnection. And an incomplete disconnection is most likely the most important cause of the failures. Sometimes it's pathology related, and I'll give you some examples. So it's easy to have an incomplete disconnection when the anatomy is very distorted. We need to remember that our procedures are done by an anatomical basis, and when the anatomy is distorted, there is a higher chance for an incomplete disconnection. It has also to do with the surgical experience and also with exposure. So here is the outcome versus related to etiology. As you can see here, the outcome varies from perinatal strokes with 70% seizure-free to Stugge-Weber, which is our best group, 88% of those patients, they are seizure-free, to our worst group, which is MMAencephalo, which is a type of cortical malformation that only has 50%. This is an example of an MMAencephalo, and you can see here, this is a hemisphere with a larger malformation here on the front, less in the back, but you can see here how this malformation invades the contralateral side. This is difficult for the surgeon to perform the disconnection, the complete disconnection, because there are no good landmarks. So in those cases, that's the reason why probably the outcome is less MMAencephalo, because of the incomplete disconnections, because it's easy for it's more complicated and easy for the surgeon to leave a small portion of the brain still connected because he's concerned about going to the contralateral hemisphere. And this is an example when you have an incomplete disconnection, a patient that with MMAencephalo, disconnection was performed, and you can see here that there is still presence of contralateral hemisphere, ipsilateral hemisphere still connected to the hemisphere, and that's the reason of the failure. So when we perform the anatomical disconnection, again, we can remove the entire hemisphere. We can see in more details where the disconnection is still persists, or the tissue is still connected, and we can make those patients seizure-free after reoperation. So in general, when the patient, they have persistent seizures after hemispherectomy, and we recognize there was an incomplete disconnection, the reoperation will bring seizure-free in almost 50% of those patients. So this is to highlight to you the value of reoperations when we clearly define that there is an incomplete disconnection and we can go back and then complete the disconnection. This is another example of an incomplete disconnection here with a functional hemispherectomy. You can see here the remaining of the connected tissue here on the frontal areas and also in the splenium, as you can see here. And when you go back and remove and disconnect the splenium, those patients, they do become seizure-free. So this is to highlight to you what are the importance and the value of reoperations in those patients, mainly when we identify that there is an incomplete disconnection there. And this is more common in pathologies where you have distorted anatomy, for example, as MMAencephalo, for the reasons that I explained to you. So we do have imaging techniques that can predict if there is an incomplete disconnection. So one of the tests that we do is the DTI, diffusion tensor imaging. It's a radiological test that we can see the fibers, and you can see if there is fibers still connecting, for example, here in the rostrum, still connecting to the contralateral hemisphere. We can probably say there is still a connection. It's worth to take the child back to surgery in order to complete disconnect. So those are radiological techniques. We need to be very, very careful because they are, when they see a connection there, of course, there is a connection and it's value to take the patient back to the OR to disconnect. But sometimes when the DTI does not see the disconnection or does not see there is a connection, still there is a chance there will be a connection there because the specificity or the chance, how clear this imaging show this connection is not 100%. So my take-home message is probably the best test or the best information comes from the surgeon, comes from your epileptologist. Do they believe the seizures are still coming from the ipsilateral hemisphere that we did surgery? And do we believe that the surgeon still, there are some areas in the brain that maybe is still connected? If there is this impression, it's worth to take the patient back to the OR in order to complete this connection, even if the DTI does not show completed disconnection. So in summary, this is my last slide. Anatomy, etiology, and techniques are all important and need to be considered on an individual basis. I want to emphasize that one of the most important values here is the surgeon experience, what technique he's used to. Failures needs to be carefully evaluated and considered, maybe with a surgeon impression in the OR, maybe with your epileptologist's impression, and also with the DTI, but be careful with the DTI. All patients are improved with acceptable risks of surgery. There is a tendency to minimize risks, and long-term outcomes studies necessary to better understand the natural history and long-term risks. So still a lot of research to be done to understand. Thank you.